Hello and welcome everyone to our channel. Today we will be discussing on buffering of metabolic acidosis in critical illness. It will be an overview of buffer power and its clinical implications. Metabolic acidosis occurs when there is a decrease in the base excess in the extracellular fluid. It's common in critical conditions such as sepsis, acute kidney injury and fluid resuscitation. Its key components are acid load, body's buffer systems, respiratory and renal compensation. Buffer power, or beta, in metabolic acidosis. Definition of beta. Buffer power, or beta, refers to the body's ability to neutralize an acid load instantly. Formula is as shown. Includes bicarbonate, hemoglobin, and albumin as main contributors. Clinical relevance. Higher beta indicates better buffering capacity, providing resistance to rapid pH changes. Main buffers in extracellular fluid, carbonic buffers, primarily bicarbonate. Non-carbonic buffers, hemoglobin, albumin, inorganic phosphate, and 2,3-DPG. Mechanism. Buffers resist pH changes by neutralizing acids immediately. Clinical note. Phosphate and 2,3-DPG contributions are minimal in acute settings, so only bicarbonate, HB, and ALB are used in clinical calculations. This figure demonstrates the acid-base changes in a COPD patient as they progress from a stable condition to pneumonia and then to metabolic acidosis in the ICU. Stable condition, home, carbon dioxide, PaCO, is high, 60 mm of mercury, due to chronic respiratory acidosis. Buffer power, beta, mostly provided by bicarbonate, carbonic buffer, with some non-carbonic buffering. pH. Stable at 7.35 with a high standard base excess, SBE, of plus 7.4. Pneumonia, ED, carbon dioxide rises further due to worsening respiratory function, contributing to respiratory acidosis. Bicarbonate, hydrogen carbonate, increases as a compensatory response, slightly raising buffer power. pH drops to 7.25, with SBE reduced to plus 7.7. Metabolic acidosis, ICU, now, SBE decreases significantly, minus 12, marking severe metabolic acidosis. Despite buffer efforts, the pH drops further to 7.10. Overall, this patient experiences a combined respiratory and metabolic acidosis, with the cumulative pH drop from baseline reaching minus 0.25. Takeaway. In COPD patients, high buffer capacity due to chronic high carbon dioxide provides some protection, but combined respiratory and metabolic stressors can lead to substantial acidemia, requiring ICU intervention. This figure shows how a CKD patient responds to pneumonia and metabolic acidosis. Stable condition. Moderate buffer capacity with low PaCO, pH is 7.35. Pneumonia. PaCO drops further, respiratory alkalosis, slight rise in pH to 7.40, buffer capacity decreases. Metabolic acidosis. Severe drop in SBE. pH falls to 7.10 due to low buffer capacity. Key point. CKD patients are vulnerable to sharp pH drops in acidosis due to limited buffering, needing prompt management in critical conditions. Clinical implications of buffer power. Importance of this in managing metabolic acidosis. Guides choice of fluids, like balanced solutions for patients with low beta. May inform decisions on red blood cell transfusions or bicarbonate administration. Albumin infusion. Increases non-carbonic buffer power but has a negligible effect on beta. Permissive hypercapnia. Elevated carbon dioxide increases bicarbonate, potentially helpful in ICU patients with low non-carbonic buffers. Take-home message is, buffering capacity is highly variable in critical illness. Patients with lower beta are more susceptible to rapid pH drops in metabolic acidosis. Clinical relevance. Understanding beta can help anticipate patient responses and personalize treatment. Thus, recognize and monitor beta in ICU patients to optimize acidosis management and patient outcomes.